here's a sad situation, and I know of many of these, not because I go into the nursing homes as a doctor, but I know them through friends and family, that there are people in homes right now who cannot be visited because of the restrictions,
Yeah.
for fear that they're going to get a COVID infection, and they're dying alone, and they're not only dying alone, but they've made it clear, and the family is aware, that it's the idea now every day is to just keep them comfortable.
Right.
Hold their hand. They may not even know who's holding their hand, but people do it anyways.
Right.
So do we really want to sort of lock down the opportunity to visit your loved one because of a fear that they're going to get this virus? Something doesn't quite add up for me.
So welcome everybody to the COVID series. I guess we'll start calling it. I don't know. I've called it a few different things, but today is very interesting. We have a gentleman on, which I think it's timely. Last week, I was supposed to interview him, but due to technical difficulties, I was able to do so. So it's interesting that today, as you all know, Premier Doug Ford has just set out new restrictions and has locked down businesses again for the second time this year. They're saying it's only supposed to go from Monday through till the 21st, but I personally believe that it's going to go from Monday straight through till March. And today I really want to, I think more than ever, we need to emphasize or look at what's happening, if these lockdowns are going to be useful. Masks, PCR testing, and the gentleman that I have here today will be able to shed some light on all of this. So, based in Winnipeg, our guest obtained his medical degree at the University of Manitoba in 1976. He also obtained his general surgery certificate in 1984 and followed it up with his Master's of Science in Epidemiology. And he also has a community medicine specialty certificate, which he got in 1991. Since then, he has worked as a medical officer of health, first in rural and northern Manitoba, and then in Winnipeg, before his appointment as the Provincial Chief Medical Officer of Health in September 1999. And he was Manitoba's first Chief Provincial Public Health Officer. I'm very happy today to be sitting down with a credible individual, and I'd like to welcome to the COVID series, Dr. Joel Kettner. Welcome to my TCN TV network, Dr. Kettner.
Thank you very much. It's nice to meet you.
Yes, very much. Well, we've kind of met each other like 8 times, but today we're actually going to be able to speak. So there's so many places we can go. I have stuff from last week that I wanted to talk to you about. I've watched your interview before this, some interviews you've done, and there's a lot that we could go through. Let's just, let's start recent. So have you heard about these new restrictions in Manitoba, and what are your thoughts about them?
Yes, I'm aware of them, and I've heard a bit about what you just mentioned, I think the Toronto and PO regions. What do I think about them? Well, I'm sure everyone is concerned about them. They're concerning measures. They have a big impact on everybody's life. I think most people would be okay with that. Felt reasonably confident that they're necessary and that they're going to be effective. I think part of the problem for me and others is that it hasn't been made as clear as I would have liked exactly why these measures have been necessary and are still necessary. I think a common experience of people across the country been with being able to get more information that sort of measures and monitors what has been happening and measures and monitors the effectiveness of the interventions and other options have been considered and why have these been chosen. I think there isn't as much sort of transparent conversation about that as I would have hoped for.
Okay.
So that's another concern.
Okay. And I know you've talked about the appropriateness of the response that our province and Canada has even taken. Can you go into that a little bit more?
Well, when I'm a public health physician, and I just want to sort of take a minute to explain what public health medicine is compared to most of the types of clinical medicine that people are familiar with, whether it's a doctor or a surgeon or a pediatrician, psychiatrist. Those are all clinical doctors. That means that they um, they look after patients one at a time, maybe a family, but they're individual encounters. You assess the health of the individual, and if there's a condition that you have to diagnose and treat, you weigh up the how serious is this condition, what are our options for treatment, how effective are the treatments, and what are the potential side effects or adverse effects or harms of the treatment. And you do it in the context of an individual person, both short term and also think about the long term implications for the rest of their lives. Public health is very similar in all the ways I just described that we think about the interventions. But of course, we do them in the context of looking at the whole population, which in some ways simplifies the approach, in other ways really complicates it a lot, because every person in the 38 million Canadians, they're all different one way or another. They're
Right.
all in different situations in one way or another. So how do you account for all that is pretty challenging. But simple approach, it's easy to say, is how big is this problem? How big is the threat? Um, uh, what can we do about it, and what are the options, and then compare them and look at the benefits and the harms that might come from those interventions. And so the question, is this response appropriate? So that you got to go through those steps, and each one of those steps is actually quite complicated. The first important one being, what are we dealing with here? What is it about? How severe is it? Who is at risk? How is it spread? Um, and these things we didn't really know very much about at the very beginning of this. So it was natural for people to be cautious, and even I think it could be justified in retrospect that one might want to overreact and underreact until you know what you're dealing with.
Right.
But now we're 9 months later. We know a lot more about this, and we know a lot more about our options and the effectiveness of our interventions. And maybe the most important thing we know now that we didn't know, maybe some could have anticipated it, is the very profound um, harms that have come from these severe interventions, and we're learning more and more about that, which is a very concern. I think it's very concerning.
Yes. So, some of the harms that you're seeing, what have you observed in the last 9 months that I think maybe you've questioned? What have you been seeing, and what are the things that maybe we're not seeing that as a doctor you are seeing?
Well, that's a very interesting question because most of the side we think of from medical treatment is, I mean, the patient experiences it and the doctor observes it. Um, and if we just look at the health outcomes, the harmful things which are more direct to people's health and healthcare. Any doctor who's working in the system and anybody who has patients and then who or has knows a patient in their family or amongst their friends or workmates knows of the significant delays in treatment, whether it's for assessment, diagnostic tests for cancer or screening tests, even vaccinations. I mean, it's a very long list of things that have been put on hold for a variety of reasons. One of which was to sort of make sure that there was capacity in the health, particularly and the intensive care units, to treat people with COVID-19. But there's other reasons too why some of these things are being postponed and delayed, and I could come back if we want to go into more detail about those sort of direct implications for treatment. But then there's the other side, which doctors don't see this as much, because it's really what happens in everyday life in society. Whether it's 3 months out of school for children, what's the impact of that on their
Right.
learning or their growth and development? What's the impact on a I don't know the number, but a very significant number of parents, many of whom had to start working to look after their children at home, but many of whom their jobs were stopped or perhaps eliminated,
Right.
because of the impact on economic activities. And the list, I think everyone else knows the list as well as I do, of what's been closed on and off or reduced in activity. And when we talk about the economy, and sometimes you hear politicians or others saying, it's more important to save people's lives than save the economy. I don't think those statements take into account the very individual impacts of a slowed economy or of places being closed. And of course, in a way, this is not my field, but in a way it is, because we have been now for several decades about a concept called the determinant health. Sometimes people say the social determinants of health. And what that means is we've increasingly understood that although the healthcare system is important and useful to help people who need diagnosis and treatment, we also see very striking patterns of who is more likely to have severe illness, get injured, have addictions. Almost every disease one can think of, that it's a higher rate amongst people who are poor or are unemployed, more chronically, less education, lower income, etc., etc. These things, in and of themselves, are important and significant, but they also actually are associated with significant differences in health status. And so one of the secondary effects of restrictions and lockdowns is actually to worsen the conditions, the underlying social and other determinants of health. So when you're a public health doctor, you can't just look at one disease. You can't just say, okay, now we're going to put all our efforts into stopping or controlling infection. You have to look at the entire scope of the health of the population. And so you have to look at what are we just going to ignore all the other health problems?
Right.
And if our measures actually increase the rate of domestic violence, of addiction, of psychological stress, that should get our attention even more. That we'd better be cautious about, aiming all our guns at one. I don't like to use a military term. Let me think of another one. But I think you know what I mean. Like
Yes.
just focusing on one problem,
Right.
and And let me just put some of this in perspective that sometimes surprises people. I don't want to interrupt you if you have another question, because
No,
Simone,
don't
I'll
worry.
just keep talking if you don't interrupt me. So I'll just stop for a moment. But I would like to talk about, there, I stopped. I stopped for a moment. I would like to talk about numbers at some point.
We
Try to
I
put
That's my
some
next
of the, I'd
question.
like to put some of the numbers in perspective that get,
Yes. Could we put some of
because,
those numbers
we
in
just
perspective?
heard, I think it leaked yesterday, but I think it was officially, yeah. Well, I think the first thing that we need to talk about is the new modeling results that, were just by the federal government and the chief officer, because these numbers are very frightening when we hear them, if they're not put in perspective. So the latest frightening number is 60,000. Whatever that was now in the modeling. That if we stop, if we don't, if more and more contacts people, then the model we could. They always use these sort of maybe could possibles of 60,000 cases per day, which is 10 times, more than 10 times the number of cases that are being reported right now, about 5,000 per day. So that's a scary number.
Yes.
But that's cases. That's not severe cases. That's not hospitalizations. That's not ICU admissions. That's not deaths.
Right.
And that's important to distinguish. Why? Because the majority of people who get this coronavirus infection have a very mild illness. So, is the case not that important? Well, not in itself. The argument about the importance of case counts is that if we have a lot of cases and a lot of spread between people and in the community, then what's going to happen is those infections are going to find their way to that part of the population who are at highest risk for severe disease,
Right.
and the need for hospitalization and death. And that concept, that theory, is completely reasonable. That is a very reasonable theory.
Understood.
But here's an interesting. Sorry, go ahead.
No. I understood what you were saying. Go ahead.
Yeah, but just because something is sort of a reasonable concept does not necessarily it applies uh, exactly in our situation, or that the numbers shouldn't be looked at more carefully. So first, I'm going to reverse this and surprise your viewers with this belief that we have 60,000 new cases a day now. Why do I say that? Because there's been some studies show that for every case diagnosed, there's about 10 infections that have not been diagnosed. Now, that was true more at the beginning of this than it probably is now. Why? Because there's a lot more testing being done. But it's important to understand that these numbers of cases, how many cases we have, is probably more of a function of how many tests we do and on whom we do those tests.
Right.
So if we're now picking people who are more likely to be infected because they've been named as close contacts, or they have symptoms, or they work in a healthcare center or a nursing home, right? So sure, the percentage positive number is bound to go up,
Right.
and the numbers of cases is bound to go up. But how many infections are happening in the community is a more important question, and how are those being spread? And so the number of infections being so much higher than what we're testing also indicates that the rate of getting very sick, the rate of needing hospitalization, or the rate of dying, the rate is actually a lot lower than what we're measuring. So, for example, right now, using most provinces' data that use these numbers, that report them, if you break down the risk of death by each age group, say, 10, 20 to 30, 30 to 40. Well, what we see, the risk of death per case is very, very low in people under the age of 60, especially if they're healthy. And by very, I mean like 1 per 1,000 based on the case rate. But if you estimate that the infection rate is 10 times that, that's really 1 per 10,000.
Right.
And that's for all people in that age group. If you then separate out people with diseases or immune system weakness or muscle weakness, then the rate of death per healthy people in those ages is even lower. Now, is that important? Well, I think it is important. I think I've become fearful and frightened about this disease beyond the actual facts and probabilities. And maybe the best example of that is in schools. So this doesn't mean it's absolutely true, but there has not been a report of a death under the age of 20 that has not been disputed about what was the actual cause. I mean, they had a coronavirus test, and even those are like, I haven't looked in the last week or so, but they were like 2 whole country. Now, just as a comparison here, the number of deaths posted in the Public Health Agency of Canada's survey reports, there were 15 deaths in children from influenza. So one could make the statement, even though we're not completely through a full year, that influenza is more dangerous for children than coronavirus 2.
Yes.
Could actually might be able to say the same thing of people in older age groups too, 20s, 30s, 40s. But here's the biggest problem, Simone, about this whole question of comparing influenza with COVID. We never, ever, and still don't test people for influenza like we are doing for
COVID. Yes.
Like, it's COVID. It's like, and so how do you compare with confidence the two diseases? This comparison is very important. And I haven't talked about older people yet, and we need to talk about that. Why isn't? Because every flu season, we don't long. Every flu season, we do get several weeks. The hospitals are stressed,
Yes.
where the intensive care units are full with people with influenza and other respiratory viruses. So if this isn't very different from influenza, we've created a bit of a problem here, a bit of a maybe a press which concerns me a lot. So can I have people for a moment, and I'll go back to you. So nursing homes and older people. So these are the facts. No question, 80% of our deaths have been in people in nursing homes. That seems to be continued. And about the same proportion of deaths in people 80 or 85. So it's pretty clear that the highest death occurring in our oldest, most frail population.
Yes.
And some younger people, but they almost always have a pretty severe underlying health conditions. Why is this important? Well, it's important for a couple of reasons. We do not have a clear system right now that I'm aware of where there's someone who dies after a positive COVID. How do we decide if the cause of death was the COVID infection or another condition that they had for which they were in a palliative care situation or a comfort care only situation?
Right.
So it's not to say we don't care about these deaths. No, every death is a sad occasion for
Mm-hmm.
the family and loved ones. I wouldn't say it's a tragic death necessarily. Not like a health who gets hit by it. I would pretty much agree that that's tragic.
Yes.
But a 92-year-old who, who is too weak to get out of bed, may not actually recognize their family, may
Mm-hmm.
have on the chart, do not resuscitate and comfort care only. If that person gets infection with COVID, it's sort of like last straw, almost everybody in those circumstances dies. Usually, it could be a cardiac arrest or a severe stroke, but it is often an infection like a pneumonia or of a bed sore or urinary infection. That's how most of us will die, of that kind of final situation.
Okay.
But in our death certificates process, we would not put pneumonia as the cause of death, even
Okay.
if it was an influenza pneumonia as a cause of death, if it was somebody who was in their sort of, advanced stage of lung cancer, because that's what predisposed them to the pneumonia at that time in their life. Their life expectancy was very low, and the reason that died, maybe it was a week sooner, maybe it was 3 months sooner,
Right.
but they were going to die almost certainly of a complication of that condition, and
Right.
that's true for many, many other conditions. So the reason I'm saying this is, you know, here's what partly happened now to bring the mix in of the significant the deaths that we're counting, and I don't want to generalize. I'm just using this as a type of example because this is a serious infection. I'm not. I need to say this is a serious infection, just like influenza is. Even though for most of us it's not going to cause us a lot of problems. We cannot ignore it. I'm not. I just want to make it clear. I'm just trying to put this in perspective. But here's a sad situation, and I know of many of these. Not because I go into the nursing homes as a doctor, but I know them through friends and family, that there are people in homes right now who cannot be visited
Mm.
because of the restrictions,
Yeah.
for fear that they're going to get a COVID infection, and they're dying alone, and 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 they're not only dying alone, but they've made it clear, and the family is aware, that it's the idea now every day is to just keep them comfortable,
Right.
hold their hand. They may not even know who's holding their hand, but people do it anyways.
Right.
So do we really want to sort of lock down the opportunity to visit your loved one because of a fear that they're going to get this virus? Something doesn't quite add up for me.
Yeah. Yeah. Of course. And you've mentioned before that you're a little bit weary of the message being pushed out by the media about like the numbers and how they're kind of hyping this up. So do you think that with the president being set with this lockdown, do you think this is something they're going to just continue to keep doing? Because again, like they've never done this with like the flu season before. Like this is the first time we've ever seen something like this. So do you think this has set the president for the future of how they're treating even influenza? Like forget giving it the name COVID.
Well, it's hard to, this is outside of my ex now. I'm talking to you more as a citizen, I think, than a doctor, because these decisions, you know, they can't be made by doctors or public health doctors. These decisions about lockdowns and restrictions, government has to be accountable for these, because it's kind of beyond biology and medicine and public health. It's a much more complex issue of value and culture and priorities. And I think we're getting a bit of a ruffling of the deck here, because I think things were going in many ways in medicine, in other ways a little pendulum shorter to this idea that we can we can treat everything, test for everything as we get more and more technology, and therefore maybe an expectation that people don't don't have to die, don't have to have pain. We've got an answer. And where that comes from, is a more complex question, and maybe the political scientists and the political economists can answer that better than me.
Yeah.
But I really hope that this is not a precedent for how we're going to live our lives. The new abnormal, I would call it.
Yeah.
I don't want to live the rest of my life walking down the street, mask on. Nobody knows if I'm smiling or not. I don't like doing business in stores and I can't face. I don't like it. I hope it isn't an accident. But the question really, Simone, to answer is what will be the goals policies? Right now, our goal seems to be what's called a suppression goal, is to try to eliminate this virus and put a zero strategy, with this idea that we can actually contain and suppress a respiratory virus like this, and we should sort of go all out to do that, whether it's 3 weeks, 6 weeks, 3 months lockdown. There are a lot of doctors and others, but surprisingly, a lot of doctors, specialists in infectious diseases, and others who are advocating for that. And maybe they're right. I mean, but I don't get it. I mean, H1N1. There was some attitudes about the H1N1 pandemic that we should close down schools and other things like that. And then it would stop and it would go away or whatever. Well, we still have H1N1 every winter in Canada. The flu vaccines almost always include one of the 2A types as H1N1. It's a variation, maybe. We say drifted a little bit over time. But we still call it this, the same virus. Well, I don't think a goal that's going to eliminate the virus in a world, like we have, and this type of virus, which is not likely going to stop circulating. I mean, there's ups and downs in different countries, different cycles, and it's so complex with respiratory viruses that people declare a victory and success, and then a couple of months later they've got it back again.
Yeah.
I mean, yeah, we can try to close down all international travel. We can try to close down all travel within our cities. I guess it will temporarily reduce the number of transmissions. I'd rather we focus on protecting those who are at highest risk and figure out how we can provide humane care in nursing homes, and at the time try to, reasonably reduce the spread of the virus. But and there's other ways we should be able to do that for people living in the community that have higher risk. There's lots of ways to focus on that, and don't be so fearful of children and healthy adults getting exposed or infected. That's what that's my thinking, that we should be able to find a way to do that.
To
I
just
might
focus.
be wrong, and I have to listen to others, and I don't have all the data that people are collecting, which might tell them something different than what I can see.
Okay, 2 more things. Masks, because you mentioned them. Your thoughts as a doctor on the mask wearing.
So I've no doubt that masks do something. I wouldn't say that they don't do anything. It's sort of logical that, if you can reduce the droplets that spread out from talking or sneezing or coughing into the air, that you're going to reduce exposure to the virus. That's both theoretically sound, and I think there's some research that shows that it can work. When I say can work, it's because there's a lot of ways that you have to use masks to achieve that benefit, which are not easy to do. Even if you know what to do, there's practical reasons why it's difficult to put on a mask, take off a mask, use it the right way, etc., etc.
Right.
Concern about masks is the same thing as part of what I was talking about, which is, first of all, it gives the message that there's no differentiation between talking or sneezing on somebody who is a 15-year-old healthy person or a 95-year-old person living at home with chronic lung disease. If you're going to wear a mask, concentrate on wearing it to reduce exposure to your grandmother.
Right.
But you cannot maintain these restrictions for everything, for everybody, for every place. We can see that it's hard for people to do that. So, wear masks under certain circumstances. I do not think it should be necessary to wear them or sufficiently effective. The question of whether something works or not in medicine is not that meaningful a question. In other words, we don't ask, does this work or doesn't it work? We need to know to what degree does it work. We call it the effect. Does a vaccine work or not? Does flu vaccine work? Well, you could say yes, but it's like 20 to 30% effective in older people who are frail. Yes, it works, but we need to know to what degree these things work. So I don't think, again, we're getting sufficient information, nor maybe are we sort of targeting the strategies like that to where they're most useful and most important. And without giving that kind of information to the public and helping them to understand this, the risk is they'll stop wearing them altogether and they won't wear them in situations where they could be most useful or more important.
Right. Okay. And I think the last thing is this testing, which has to do with the numbers. I should have probably asked it closer. PCR testing, how effective is this? And I guess what should we be aware of, and what should people pay attention to when we're talking about testing and the numbers, just for the community? Because I think a lot of the information is going over their head. They're just kind of seeing what's being pushed out to them, obviously on mainstream. What do we really need to be paying attention to and understanding about this PCR test?
Well, it's a great question. We could spend the whole time talking about it. It's so fundamentally important. And again, it's, I'm not an expert in the sort of laboratory medicine or the complicated sort of biology and virology, study of viruses. However, here's what I know. It seems that this is quite a sensitive. What is a sensitive test? A sensitive test means it's going to pick things up more than a test that's less sensitive. So it looks like this one's quite sensitive. What does that mean? It means that if you fragment virus in the back of your nose, not one, but I don't know how many. Actually, you need thousands of them in order to pick it up in a test. But here's the problem: we don't know if a virus might be active and actively infecting the cells at the back of the nose, or it might just be lying there after the infection process is over. The person is no longer infectious to anybody else, but there's enough fragments of the virus that you'd still have a positive test. And I just learned this number. Again, I don't like to do anecdotes, but I asked an infectious disease specialist, what's the longest that a positive has been found after someone has had an infection?
Right.
And she said 72 days. Now, I'm not suggesting that that's typical, but I would like to know sort of what's the average length of time after an infection that someone is still going to get a positive test because of some virus there, or virus fragments that are very unlikely to make anyone else sick. Is it a week? Is it 2 weeks? Is it 3 weeks? This is such an important question. Why? Because someone could come into the hospital with a pneumonia. They could have a positive test for the COVID virus, but really they have a different virus that's causing their pneumonia. Okay. But they had a COVID infection 2 weeks ago, and they weren't tested at that time because they didn't go for a test. And so the assumption is that the positive test is the cause of the infection the day they're admitted to hospital or the day that they die. So there's a lot of questions here that concern me. And so if we have a test that's actually picking up viruses that are not actively causing an infection or are not able to transmit that infection to someone else, we have to ask ourselves how to interpret these tests and what should we do when we get a positive. And then there's the whole tracing issue, which is very complicated and very difficult. Again, I'll come back to my sort of regular theme for me is I haven't seen a report that's described the contact tracing results. Like, what are we contact tracing? The one question I'd really like to know is what do we know about how that series of contacts ended up exposing someone at high risk for disease. They got sick and needed to be hospitalized. Where did they get that from?
Right.
Directly or indirectly? Because if we're going to start closing down, as we are doing, a whole bunch of different settings and places, I would like to hear what the evidence is that that is where the transmission is happening, and even if it is, how do things sort of go from there to result in what we're really most concerned about, which is this virus landing, on somebody who's going to need hospital or care or ICU care or die from it. I haven't seen any information that's analyzed that, and I don't know on what basis or evidence these various restrictions or closures are happening. It's not good enough to walk by someone's yard and see 15 people having a party in the backyard as evidence that that's the cause of the problem. I don't think that's sufficient evidence.
Agreed.
And that's where we're hearing a lot of the anecdotal reports, and I don't know, maybe it is, maybe it's not.
But where's the evidence to support that? That's the question. Where's
I don't
the
know,
evidence?
did I answer your question about the testing?
Yes, kind of, sort of. Just if it's because these are the tests
And
that are determining the numbers.
in fairness to public health, sorry.
Uh-oh, did we freeze?
Yeah. Now, don't get me wrong. I'm not saying that all these test results are irrelevant or they're not valid or that they're just picking up dead viruses. I just like to know more about how accurate these tests are from that perspective.
Right.
And there are ways to study that, and maybe they've been studied, and maybe I just don't know literature enough. But I shouldn't have the literature for this. This should be who's with the intermission would like to have. I think we could be a little more critical, of at least ask questions, if not be critical of the policies. But it seems like I don't think in public health doctors in general or infectious disease doctors in general that are being interviewed or speaking to the public spend so much time on critical analysis of what's happening and why should it happen or why shouldn't it or what are the effectiveness or harms, rather than what they're often spending more time doing. This isn't fair to generalize. There's others. I'm not saying everyone does, but many, especially the public health officials, seem to be just telling us what to do and what not to do and why we must do it, without as much explanation as I would like to hear from them.
Agreed.
Does that make sense, what I'm saying?
Yes, absolutely. Absolutely. This is why you've always had questions. That's one thing I've always heard you say is, I just have questions. Like, you're questioning. It's okay that they're doing, but why? What's the evidence that supports?
Yeah, and so I'm glad you said that, because it reminds me of another point that's, I think, to make in this context. It's easy for me, I'm retired. I'm not retired, I teach things, but I'm not working for government health as I have in the past. So it's easy for me to, sit in my armchair size and say, you guys don't have enough evidence for what you're deciding. that would be very unfair of me, and I can only sympathize with my colleagues for the difficult situation they're in. And here's the point I want to make. You can't always have the evidence you want, especially in something that's newly emerging. So, so you can't, it's not fair to full evidence for the decisions that are being made. And I don't really ask for that. I ask, just share with me what you've got. Share with me your homework. Share with me what information you are using and what is your rationale for the decisions you're making. Doesn't have to be perfect. I don't expect the decisions to necessarily incite work or work as well as we hoped. But I would have a little more strongly in February and March than what I'm saying now. Is we actually do have more evidence. We actually have learned quite a bit about this virus, how it is spread, who is at high risk, what are the different would intervene. We know a lot more. And part of my disappointment stage is that I think there's been lots of opportunities, even just to use the data that we should be monitoring, and we call it surveillance. It doesn't even have to be fancy research like randomized trials, which ideally you'd want to take Montreal and say everyone wears masks, and Toronto nobody wears masks, and then see if there's a difference.
Right.
Of course we can't do that, and partly it would be very hard to draw conclusions because in Montreal you say bonjour and in Toronto say hello, and I don't mean to be facetious about that. The cultures, of course, they're different.
Yes.
I love being in Quebec. I love being in Montreal. I love being in Toronto and Ontario. I have children in both provinces, but they're different. So it's very hard to do sophisticated research to answer our questions. But everyday surveillance and monitoring, we should have been doing if we haven't been doing it, and we should have been doing it with enough detail that we could at least describe what has been happening. And I think there must be more data I know about, or more data than is being shared. Even the patients that are in hospital, or the patients that are in ICU, or the deaths, could we please know more about, how was the diagnosis made that this was the main reason they were in hospital?
Right.
Or what is the main cause of death that was decided? Or who is in the ICU? They're not the same as the patients who die, because if 80% of deaths are nursing home, typically people in 80s and 90s do not get admitted to the intensive care unit. So who is ICU? Like right now in Manitoba, about half of the patients in the ICU are told COVID-19 case. Again, to what degree COVID plays a role, I don't know. But I just would like to make one more point about this. Sometimes these situations are to describe the situation in our health system that makes it look like we have a very special problem right now that we don't usually have. That's fair. Why do I say that? Well, normally an intensive care unit is 90% full because you don't want to. You've always got patients in the rest of the hospital who may be on the verge of needing intensive care, and you're trying to manage them on the ward, and so you don't keep half your beds empty. You take those patients in if you have room for them.
Right.
So there's usually a small percentage of beds, maybe 10%, that are kept open as best as possible. But now the news is we don't want to have so many cases now, because we don't want to put our doctors or our families in a situation where they have to decide who's going to live and who's going to die because there aren't enough beds or healthcare workers in ICU. And very interesting conversation in Manitoba over the last week or so about what is the protocol, the triage protocol, because surely there must be one in place because you have to triage patients all the time as to, who's going to get in, how soon are you going to discharge somebody. We actually had a special plan for this during H1N1 in Manitoba, where we put together a group that looked at them from an ethical and equity point of view, because high of our IC patients during H1N1 pandemic were NS patients. So we wanted to make sure that there were equity considerations in the decisions about and discharge. These triage calls, surely they've existed, and people should know that decisions are made every day about who's going to get dialysis and who isn't, who's going to get admitted to hospital and who isn't when you've got a hospital that's full. Now, is that a bad thing? Well, yeah, it sounds bad, and we would like to treat everybody that we think we might be able to offer some benefit to, but that's realistic. Unless we spend even, more than 50% of our budget on the healthcare system. If we want to go 75% of our budget, and build more hospitals and more beds and more ICUs, we could. And that maybe would be less often that we have to sort of make a hard decision. But we've got to balance our priorities here. And that means, it means realizing that, again, coming back to my earlier comment, COVID-19 is not the only problem we're facing.
Right.
I'll just give you one more number.
Okay.
Deaths. Let's talk about deaths.
Okay.
So, big number, 12,000 deaths in Canada associated with COVID-19. Let's even assume that was the main cause of their death. And of course, side of the coin is there may be people who died of COVID-19 that didn't get diagnosed. So we got to be careful not to just look at this one way, one-sided.
Right.
But the way we're testing now, I think that's pretty unlikely that that's happening very often right now. So 12,000 deaths. So every year in Canada, there's about 300,000 deaths. We're almost a year now of this disease. So that's not totally a fair number. But if you think of it per day, it looks like between 5 and 10% of all deaths are associated with COVID-19. Now, it's not a small number. Like, I'm not saying, oh, that's nothing. But it is not the most common cause of death. And when we announce these deaths every day, 60 or 65 deaths, it's about 5% deaths. We don't say, we're not telling Canadians today we had 15 deaths from lung cancer and 10 deaths from emphysema and chronic obstructive lung disease. Therefore, if you're still smoking, maybe these facts will help you decide not to or try to reduce. Or how many deaths are due to overuse of alcohol? I mean, there's lots of them.
Right.
We don't announce these every day.
Nope.
And we don't talk about the prevention measures that people could be reminded about when they're looking you in the eye. So why not? As a public health doctor, I have to think of this from a broad population perspective. Now, if I was an ICU doctor, I would do what the ICU doctors are doing, which is to describe the pressure they're under and ask the government to find a way to slow down the number of new admissions to the ICU. To what degree they're COVID or not requires a little more analysis. But I get that. I think that's the perspective they should have.
Okay.
I'm a little disappointed when my colleagues in the ICU say that they ask the government to lock down for 3 months. It seems to me that maybe they don't have the expertise about how to prevent disease. Like, they can have an opinion, but I'm not going to the government to tell them what type of new ventilator I think should be putting in the ICU. Anyway, I don't really want to say what I'm saying right now because it's coming across that I'm criticizing colleagues. I'm not. What I'm
Okay.
trying to say is they're doing right. They're concerned and they're telling government, and there's no doubt if we lock down for 3 months, probably it might reduce patients that come into the ICU
Mm-hmm.
from COVID. Yes, I mean I don't want to. How effective it would be, what impact would it have on other reasons why people might come into ICU? Like
Yes.
I've heard of patients with short of breath, cough, uh, and normally they would go to their doctor or to the hospital to be assessed. They're not going. They're not going because the waiting times are crazy
Yeah.
right now. I shouldn't use that unscientific term. And some of them are afraid of getting COVID,
Yes.
and I don't blame them. But, you know, in the flu season, we encourage people to come to the hospital with symptoms like that, even though, yeah, influenza's in the hospital.
Hmm.
These respiratory viruses, they've evolved for like a billion years to spread.
Mm-hmm.
And it's interesting. See, yeah, how many more hours have we got, Simone?
You're almost done. You're almost there.
Can I make this last point? Did I say last
Okay.
point before?
Yes.
Okay. Well, then let's put this now into an ecological perspective.
Okay.
This is a very, very well evolved virus. It's an elegantly evolved virus. Why do I say elegant? Because it is evolved so well that it does what a virus needs to do if it's gonna last as a species for a long time. It's not really a species technically, but you know what I mean. It does not want to kill its because it depends on being spread from a host to another host. If it kills its host too quickly, it ain't going to get spread around, and the gene connect the gene structure in that makes it so virulent that it kills its host will not stick around, will not enter the gene pool. But it has to make the patient sick enough to cough and sneeze, because that's how it
It
spreads
spreads.
from
Right.
one to another. If it stays with one species its whole life, it's not going to do very well, because that host stays with one host. That host is going to die.
Uh-oh. Did we lose sound? We lost sound.
Which was a little bit,
Could you
what's
go
the word
back a
I'm
little
looking
bit?
for?
We lost
It was a
sound.
little bit.
Dr. Kettner? We
Oh
lost
yeah, because
sound
I
for a
had a
minute.
phone call coming in. Can you hear me
Okay.
now?
I can hear you perfectly
For the
now. Yes.
last hour and a half. Okay.
Yes. We just need this last few minutes. We're almost there.
Okay, but where did you lose me? By talking about the elegantly evolved
Evolved
virus.
virus. Yes. And how it needs to be
All right, so I'll
transmitted.
just say this is yeah, it needs to be transmitted,
Mm-hmm.
and it's not good if it kills its host too quickly.
Right.
And so this virus has pretty got a very good balance. It doesn't kill its host. In fact, it kills a very small portion of hosts that it gets to, and it causes a infection. So people aren't bedridden. They can go out and socialize and visit and go to work. Often they don't have any symptoms at all, and still they can spread, especially with very close contact. This is the perfectly evolved virus for spreading and hanging around this world
Mm.
for a long time.
Hmm.
It's going to be a hard one to be. This is like Elmer Fudd going after a rabbit. Like you never did get one.
Never gonna get it. Okay.
Now, I'm being a little silly. I'm being a little bit,
It's okay.
cartoonish. And of course, there are ways to manage viruses like this. There are, but um, I'm not that confident that even with the most sort of strict um, restrictions and lockdowns, it may temporarily seem to lower the count,
Which is
especially if
good.
we don't test so much. That'd be a really
Hmm.
good way to end the high cases. Stop testing. Uh, yeah, I shouldn't be so lighthearted about this, but one way to get through these tough times is to be able to
Smile,
laugh a little bit about it.
of course.
I just hope I'm not being, yeah, I just hope I'm not being seen as disrespectful or
No,
flippant,
I don't think so.
because I don't feel that way about this. But but it's a tough one. And then the big question we haven't talked about is the vaccine. And
Yes.
and I really hope it's a great vaccine. And if I hope for anything about the vaccine, it's that it can protect people at highest risk for severe disease. The problem the challenge there is that most vaccines, especially like influenza vaccine, don't do as well for the people that most need it.
Mm.
But word is out that it's working well for older people and maybe people with other health problems. In which case, I think it could be a very useful uh, vaccine as a vaccine. I'm less confident that it can actually cause, achieve herd immunity to snuff the virus out from circulating.
Mm.
It would have to be a really, really good vaccine to do that. And more importantly, a very high percentage of our population would have to be willing to get it. And it looks like all of them get 2 shots. So it's tough. It's going to be a tough challenge to achieve what we're looking for with the vaccine. But I don't want to be pessimistic. I don't predict the future at all. I'm just sort of reflecting on the facts as I best know them.
It's appreciated, Dr. Kettner. You know what? You
Um,
gave a
I don't know.
much.
What do you think, Simone?
What
I've
do
been
I
doing all the
think?
talking. What do you think?
Oh, oh boy. Okay, so I don't think the
This has been a
lockdowns have
very
helped.
one-way conversation.
I'm a listener because I want you have the knowledge and I want you to deliver the knowledge. I'm just reporting on it and writing about it, right?
Yeah, I
So
know. But actually, I'm trying. I'm also. I know I'm kind of making fun, but I also am trying to make a serious point. And coming back to a point I made earlier, I'm not sure that this is primarily a medical question where we need to hear the experts tell us what they think or what we should do. I would like to have much more of a sort of democratic participation from everybody in contributing their observations, their concerns, their thoughts to this, um, because as we go on more and as we anticipate this could go on a really long time, I think that's who should be making the decisions, not the public and their elected representatives. Not the doctors should provide some information.
right.
This is, I think, a lot of this is what ordinary people. I shouldn't use the word ordinary. Uh, every person, can observe what's going on and should have an opinion about what they think is the right balance between prevention and 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 life
But they
and
need the
life.
information, and that's what it is. I don't think they're getting fed the right information. I think they're getting fed one sided, and they're making all their decisions off that one sided information. And this is why I do these interviews because people need to see some balance. They need to get perspective from different minds, different experts. It's important, which is why we do this. So thank you. Thank you. There's a lot of different things that you gave us to think about. So appreciate it.
You're welcome.
You were saying something?
Well, I appreciate the chance to talk to you about them.
Thank you. Thank you so much. And you are not even aware. You're away. You're isolated right now yourself, aren't you?
Yeah, well, I'm not isolated in the sense that I'm a case or a contact. But I'm following the rules. I'm following, and even if I may sound critical or at least questioning them, it's important for me to say that I do not advocate that anybody not follow the
The
rules
rules.
or the advice, and I do that. I do that as best I can.
Okay. Well, Dr. Kettner, thank you for your time. Like, I know we were late starting and we had some technical difficulties, but you've given me enough to provide information for the community, and that's exactly why we're doing this. So, thank you. Stay safe and feel free to continue to share with us anything that you learn. Again, you've been in this field for a long time, so there's still some knowledge that you can present to us that we can utilize. So, really appreciate it. Thank you for your time.
You're very welcome. Thank you for having me on your show.
You have a wonderful day, and we will catch up. And you'll get a copy of this interview. Okay. Bye, Dr.
Great.
Kettner.
That's great. Thank you.